Thank you, Professor Byung, for this very informative presentation. It is really interesting to see all this advanced treatment for thyroid cancer and for colorectal cancer. I'd like to invite all the speakers to come to the podium for question and answer session. Professor Jae Wook Lee, who presented the SCC surgery. Professor Jae Wook Lee, pediatric solid tumors. Professor Jae Wook Lee, post-allogeneic transplant, and Professor Byung Soh Min, a super expert in robotic surgery. And we have received many questions because this presentation or seminar was attended already by more than 331 attendees. So it's a big attendee for this region. And we really appreciate all what you presented. I have a question here regarding a child who has hepatoblastoma tumor. So the questions are concentrating regarding pediatric treatment for hepatoblastoma and then surgical approach for that. So maybe if Dr. Jae Wook Lee and Dr. Jae Wook Soh will comment on this case, please.
Yeah, the treatment of hepatoblastoma depends on the stage of the tumor. So if the tumor involves the both lobe of the liver, then you can use the chemotherapy first. And then if the tumor the tumor size is decreased, then the operation such as hepatectomy can be performed. So you can use the combination of chemotherapy and surgery for the treatment of hepatoblastoma.
All right. Anything specific about the surgery for hepatoblastoma by Professor Jae Wook Soh?
Yeah, can you hear me?
Yes, please go ahead.
Yeah. If the first line treatment for hepatoblastoma in pediatric patient, there should be the chemotherapy. If the trials show the response to chemotherapy, and then we can think about surgery such as the hepatectomy or the liver transplantation in very selected cases. The surgery would be definitely curative treatment of the hepatoblastomas, even in the patient with the very advanced stage of hepatoblastoma.
Right, great. Professor Song, stay because I got a few questions regarding hepatocellular carcinoma surgery. So one of them is like, you know, certain percentage of hepatocellular carcinoma will not have elevated alpha-fetoprotein. I think in this region, 30 to 40% of the cases will not have elevated alpha-fetoprotein. And then the question comes, do we biopsy those tumors, or we can just accept the imaging criteria to say this is hepatocellular carcinoma, and then we can proceed with surgery?
As you know, the liver biopsy is not usually recommended for routine procedure for the diagnosis of HCC.
It is not recommended. It may spread the tumor, correct? Can it spread the tumor?
There is some concern about the spread of tumor and the procedure-related complications such as bleeding or the pneumothorax or the intraabdominal bleeding. And we can diagnose the HCC accurately with the CT scan or MR. The biopsy is not routinely recommended for diagnosis of HCC.
So you agree that in many cases we can just rely on the CT and MRI criteria to call it? Okay, great.
The interpretation of the CT, especially MR, suggests that the probability of HCC over than 90%, then in such a situation, we don't need to perform the biopsy.
All right, good. Now you have discussed that you can operate on advanced hepatocellular carcinoma, even with portal vein thrombosis. So in some cases like this, a lot of colleagues will prefer to start with anticoagulation. Maybe the portal vein will open up. What do you think about that?
I don't think so. That's the role of the anticoagulation, including the warfarin or some kind of the LOA, is very limited in patients with foreign tumor thrombosis, because the nature of the development of thrombosis is quite different from the benign thrombosis. So in such a case, if the patient is feasible for the resection, we must consider the surgery without anticoagulation before operation.
All right, thank you. Another question I have for you. If you have locally advanced hepatocellular carcinoma, and on the imaging study, portal vein lymph node involvement, so regional lymph node involvement is noted. So in this case, would the case be a surgical candidate?
The accurate diagnosis of the lymph node involvement based on the imaging study is very difficult. But definite enlargement or the increasing size along the follow the imaging study, there are high probability of the lymph node involvement in HCC. But as you know, the incidence of lymph node involvement in HCC patient is relatively very low compared to the billing or pancreatic malignation. So in a real clinical practice, we are considering surgery as a first option, even in patients with the suspicious lymph node involvement, because the primary reason should be controlled by the surgery, and then lymph node involvement can be controlled or should be controlled with the following the treatment, including radiotherapy or the chemotherapy with the sorafenib or another target agent. So surgery should be the primary option for treatment.
I have a question here that from a patient. He said he had low-grade neuroendocrine tumor of the pancreas, and he underwent Whipple surgery for that. However, he has several lesions counted as 6 in the liver. So 6 lesions at least, and low-grade neuroendocrine tumor. Would you offer surgery in such a case?
Maybe if the involvement of the reason is the bilateral, and this cannot be controlled by the conventional surgical resection. In such a situation, we usually recommend liver transplantation. This is the
liver transplant. All right. Okay. Very good. There is a question that in this region, a lot of intrahepatic cholangiocarcinoma is seen, maybe as much as HCC. So how do you approach such cases, especially if they have obstructive jaundice?
In the surgical strategy is similar to the strategies which is used in the management of the cholangiocarcinoma. In such a case, we have to perform the biliary decompression by the endoscopic approach or the percutaneous approach, I mean the EMBD or PDBD, and then we wait the stabilization of the function, and then we assess the functional reserve of the underlying liver, and then we consider the feasibility, technical feasibility of the surgical resection. It depends on the presence of the vascular involvement or the future remnant volume after carotid resection, etc. So I think very controlled by the similar management protocol which is used for the cholangiocarcinoma patient.
Thank you, thank you. I'm getting a lot of questions really from the audience. So, you know, in advanced hepatocellular carcinoma, a lot of doctors use sorafenib and then later on lenvatinib, but now there is another regimen of Avastin plus atezolizumab, which is FDA approved, and it seems to be promising. So some of us may be intrigued to offer this regimen first. Maybe it will shrink the tumor prior to surgery. What do you think about that?
In the personal experience, I have the rarely experienced in the case about the beneficial or some effective use of the sorafenib before operation. As you know, the response rate, especially if patient is a very huge HCC or the proven tumor, this response rate to the target agent such as sorafenib, levorafenib, or another of the even in the immune checkpoint inhibitor is very low response rate. So if the technically feasible, anatomically feasible, you have to remove the primary reason first, and then we consider the adjuvant treatment or the palliative treatment, molecular reason or random reason. In the surgeon's perspective, the surgeon's viewpoint, the surgery must be the primary option for treatment of even for locally advanced HCC.
So very clear that start with surgery, then use the new modalities of treatment if you wish to use. All right, great. We have also a few questions to Professor Jae Wook Lee, pediatrics. So I have a question here. Thank you, Professor Song. I don't know, stay around because we may have few other questions maybe from the audience. So now for Professor Jae Wook Lee, there's a question here that when do you time the surgery for neuroblastoma with the treatment of chemotherapy, transplant, etc.? So when is the best time to proceed with the surgery for neuroblastoma? I was not given what stage.
Yeah, if the tumor is very small and it's very easy to operate, then we can do the surgery at the time of diagnosis. But usually the tumor size is very large in the high-risk neuroblastoma. So in case of the large tumor, we do the 6 cycles of chemotherapy and then we perform the surgery. But in case of inoperable tumor, even after the 6 cycles of chemotherapy, then we can postpone the surgery after the tandem high-dose chemotherapy.
Okay,
so I think it depends on the size and the operability of the tumor. Yeah.
All right. I have another question for Professor Lee, pediatric oncology, and Professor Lee, transplant. 12-year-old UAE female had Hodgkin's lymphoma, and she was treated with chemotherapy followed by radiotherapy abroad. And then shortly after that, she had a relapse, and now transplant is discussed. So the question is, when do you time transplant, number one? And then the other question that in adult patients, the antibody brentuximab vedotin was incorporated to some regimens, or the immunotherapy drug pembrolizumab was also incorporated. So in a pediatric patient who had relapsed Hodgkin's lymphoma, how do you manage in 2020 in Korea? So the question is relapsed Hodgkin's lymphoma. Professor Lee?
I think
Hello.
it's better.
So I think.
So we'll start with Professor Jae Wook Lee, transplant, pediatric transplant. please.
So I think the first goal should be to gain a definite second complete response. In our institution, and I think in many institutions around the world, they use many regimens. We prefer to use an ICE regimen based on ifosfamide, carboplatin, and etoposide initially. We usually have a good response to that. And in terms of the first question concerning the timing of transplant, I think the patient should undergo high-dose chemotherapy and autologous transplantation as soon as a good second CR is achieved. Concerning the second question, concerning the novel chemotherapeutic regimens that have been introduced, we have used brentuximab prior to, and actually for post-transplant relapse also. So brentuximab can be used either prior to or after transplantation. In terms of the checkpoint inhibitors such as brentuximab, I strongly suggest using it prior to transplant as a mode of salvage therapy. If you give it after transplantation, although there have been some studies that saying that checkpoint inhibitors can be used safely in the post-allogeneic transplant setting, if you give it after allotransplant, there's a high risk of very significant and severe GVHD, which we have experienced. Thank you.
Right. Yes, thank you. Thank you. I have a question to Professor Jae Wook Lee, pediatric oncology. You presented this case of PED scan, where it detected ALK mutation. So do you have like a special isotope for ALK mutation? And in fact, nowadays there are certain isotopes, for instance, for HER2 receptor. So would you comment on the different isotopes that you can use other than FDG PET to diagnose specific cases with molecular targets?
You mean the isotope for the immunohistochemistry?
Right. I mean, remember this case of myofibroblastoma tumor? Myofibroblastic tumor?
Yeah.
So the ALK was in the blood, or it was by PET scan contrast that can detect ALK mutation?
The ALK mutation was detected by the next generation sequencing method, not the immunohistochemistry. So we used the NGS panel to detect the gene mutation or the translocation. So the method I present was the NGS technique in our case.
Okay. Okay, thank you. I have a question to Professor Jae Wook Lee regarding you discussed the case of acute lymphoblastic leukemia with Philadelphia chromosome. So one of the audience physicians is asking about the role of imatinib in such case.
Right. So it's the introduction of imatinib and other TKIs has really revolutionized the treatment of Ph-positive pediatric ALL. Many institutions now, I understand, give imatinib in the middle of remission induction chemotherapy. At our institution, our policy has been to start either imatinib or dasatinib after the patient has achieved first CR. The patient would undergo chemotherapy combined with TKI therapy. Again, many institutions around the world, I understand, depending on the response of the patient to chemotherapy plus TKI, rather than undergoing allogeneic transplantation in first CR, these patients would continue on with chemotherapy. However, the results from our institution seem to suggest that continuing with chemotherapy alone without allogeneic transplantation is first CR. These patients seem to have a lower event-free survival. So our policy so far has been to maintain these patients with chemotherapy combined with TKI, and then undertake allogeneic transplant in first CR. But that is just our institution. I understand now that many institutions throughout the world treat these patients with chemotherapy combined with TKI only without undertaking allotransplant in first CR. That would be extremely effective in terms of limiting the toxicities of transplantation. But at least for our institution, I think we need some further study on that point. Thank you.
Thank you. So the answer that you still consider stem cell autologous stem cell autologous, right? Or
Allogeneic transplantation.
Allogeneic transplant in the first line after induction. And
Yes.
okay, all right. I have a question regarding like patients who are not full match. So what kind of numbers you will accept to offer allogenic transplant, and then you can offer the techniques to reduce GVHD.
Right. So usually in terms of when we talk about a matched, fully matched, HLA fully matched unrelated donor at our institution, we usually look at the minimum, which is really 8 of 8 alleles, HLA, ABC, and DR. Many institutions include DQ so that they're actually looking at 10 alleles. We just basically, if the donor and the patient are fully matched at 8 alleles, then we consider that a fully matched donor and recipient pair. So we would undertake allogeneic transplant. For patients who do not have a fully matched unrelated donor or a matched sibling donor, there are various options now available, including a mismatched unrelated cord blood. And for many patients nowadays, a family mismatched haploidentical family donor. So these two options we have been using quite a lot recently.
All right, great. Now we move to a few questions to Professor Byung Soh Min from Yonsei University College of Medicine regarding the fascinating presentation on robotic surgery. So the first question I have here, what is, I think you mentioned that, but just to recap, what are the advantages of offering robotic rectal cancer surgery versus laparoscopic rectal cancer surgery?
That's a very good question. Although there's still some controversies going on, but literature says after robotic rectal cancer surgery, the function preservation rate, including sexual and voiding function after the surgery, is superior than laparoscopic surgery when you perform robotic surgery. And recent few articles cautiously show that in case of the difficult rectal cancer, for example, low-lying after preoperative chemoradiation and heavy male patients, in those extreme challenging cases, robotic surgery may show superior oncologic outcome than laparoscopic surgery. But that's at this moment that's a still very limited report. So we should see. But I would say the current literatures are very encouraging.
Okay, one of the attendees is an ENT surgeon, Dr. Nawal, and she was asking about is there any advantage of robotic surgery for pituitary tumors?
Pituitary tumors?
Yes.
Oh, pituitary tumors. I am sorry, but we don't really have experience for doing pituitary surgery with robotic systems at this moment. Right. I'm sorry.
All right. Regarding the transaxillary robotic thyroid surgery, so you're taking the thyroid gland from the axilla. In this case, you mentioned that you can do it for micropapillary thyroid cancer, meaning less than 1 centimeter. But if a patient has malignant tumor higher than 1 centimeter, what is your recommendation? Robotic or other modality of surgery?
Before I answer the question, I have to apologize that I'm not an expert in thyroid cancer, but as far as I know, that really depends. The tumor has invaded the extra capsule of the thyroid and the lymphatic metastasis of the central node and the neck nodes around the thyroid. So if tumor confined in the thyroid gland, our thyroid surgeon, expert thyroid surgeons would still perform robotic or other minimal invasive approach for thyroidectomy. And sometimes they also perform the radical neck dissection using robot. But if tumor is a bulkier and has exceeded thyroid extrathyroid capsule, then and invading adjacent structures, then maybe robotic surgery is contraindicated.
All right. I have a question regarding rectal cancer surgery. So because with robotic surgery, you're probably going to use the smaller incisions. Is there any risk of seeding the tumor to the surgical scars when you extract it out?
Well, that pattern of the recurrence, the recurrence at the trocar insertion site or mini laparotomy site were the problem during the initial experience of the laparoscopic surgery. It was a worldwide phenomenon. But it suddenly disappeared with the cumulative experience of the minimal invasive surgeons, collective experience. So I would say at this moment, in general, those kind of recurrence pattern is not very common one, and usually related to the very extensive type of cancer. So yeah, that's very rare case, I would say.
All right, Professor Byung, I have a question like somebody asked this. He said, nowadays we have several hospitals that are putting Da Vinci robotic surgery machines in their centers, just in you. And the question is like what you said, it's operator dependent. How can you verify that the robotic surgeon or who claims that he is robotic surgeon, that he is trained enough to do it? I know, for instance, in breast surgery, for sentinel lymph node biopsy, the American College of Surgeons did request that you have to do certain cases or you have to go through specific training. And you've also mentioned that you are a training center. So please advise us in a very, I'm sure it's an honest way, what is the minimum requirements for a safe robotic surgeon, please?
We do have a training course and certain prerequisites before he or she becomes a standalone robotic surgeon. And those training courses actually is separated by the trainee, whether the trainee is an internal, I mean, he works in our institution or came from the other institution. So in case of the other external trainees, that really depends on his or her surgical background before he started robotic surgery. So if he or she is an expert in laparoscopic surgery, then their learning curve or their prerequisite for before mastering robotic surgery would be relatively shorter than those who are not very experienced in laparoscopic surgery. And in Korea, we are working on the making, officially authorizing kind of a certificate before a surgeon start, standalone, becomes a standalone robotic surgery, but it's not yet started. Yeah, I would say that, yeah.
So like a laparoscopic, let's say I have a skilled laparoscopic surgeon and he wants to learn robotic and become independent, solo independent. How long does it take if he goes like to a center like yours?
Usually at least 6 months, because before he or she performs robotic surgery by themselves, we require
Yes.
he or she to be attending at the patient table assistant surgeon for certain case numbers, and then under expert supervision, he or she can perform some part of the robotic surgery as a consult surgeon. So after those period of supervision, and with the approval of the supervisors, he or she may start their own robotic surgery.
Yes, great. And like you mentioned in your presentation that for colon cancer, not rectal cancer, for colon cancer, robotic surgery is offered in only 3%. So does it mean like there is no major advantage for colon cancer to do it by robotic?
I would say it's a very more controversial than it is in rectum, because
Really?
because unlike in rectal cancer surgery, colon cancer surgery is not very much standardized yet. But recently, some researchers, some pioneers around the world suggested some standardized way of doing colon cancer surgery, which is called the CME. So in that context, robotic surgery still has some benefit in doing colon cancer surgery, especially extreme challenging cases like a very obese patient and advanced disease. And usually right colon cancer surgery traditionally, which was traditionally considered a very easy one, but when you apply the standardized approach called the CME, right colon cancer surgery is very challenging, because it's related to the essential vascular structures like the superior mesenteric artery and vein. So in that cases, people are started to realize that the robotic surgery may have some benefit. And recently, in European society and also in international collaborations study groups, they started a clinical trial comparing intracorporeal versus the extracorporeal anastomosis after those cancer surgeries. And for intracorporeal anastomosis, which is considered to be more challenging technically, robotic surgical approach may have some benefit for doing that kind of difficult technique. So we will see the results after a few hours after end of those clinical trials.
We're nearly reaching the end of this interactive session. Just I have a question here. Do you have any second opinion service for physicians who wants to discuss cases prior to sending them to Korea? I know it's like an organizational question. It's not a direct medical question. I don't know if this symposium is good to discuss, or we'll leave it to the admin people. So do you have any second opinion service? Telemedicine. All right, just to conclude, there is one more question. If a patient undergoes surgery in Korea, how can they do the follow-up? Do they have to go physically back to Korea, or there are some other options? If anybody would like to answer, feel free, please.
I'm Byung Soh.
Yes, please.
As you know, we are treating with many patients from the Abu Dhabi or Dubai for liver transplantation in our center.
Yes. Yes.
So after operation, we follow the patient a couple of months in Korea, and then they come back to their home nation, and then we are touching through some local doctor working in the hospital in the Abu Dhabi or Dubai. But we have some plan for establishing some post-operative care center in the Abu Dhabi by the collaboration between the Abu Dhabian government and the Korean government. So for some more enhance the collaboration or the co-work between for the patient, the post-operative care. So we need to establish such a kind of specialized center for the post-operative care, in my opinion.
All right, great. So there may be some future further cooperation between Korea and UAE. With that, actually, time is up, and I would like to thank the panelists. We have today to coordinate this meeting. We had 11 panelists, and also I would like to thank the 300 plus attendees for this meeting. And I hope that this will not be the last mutual meeting. And thank you, everybody. And thank you for giving from your precious time in this day, which is, first of all, Friday, which is a holiday. And also it's a long holiday because of the Prophet Muhammad birthday. So we congratulate everybody, and we thank all of you for attendance. And as I said before, as you registered with your email, you will get an email after 2 weeks from this presentation asking you to fill an evaluation form. And if you fill it, you will get the 2-hour CME. And with that, that's all from my side. I am Aladdin Marrawi, Chief of Hematology Oncology at Gulf International Cancer Center in Abu Dhabi. I thank everybody, and good afternoon here, and I guess good evening in Korea. Thank you, everybody. Assalamu alaikum.